That's the last one. That's the first one. Good morning. My name is Frances Ilika. I work on the Health Finance and Governance Project, and I'm going to talk about our diagnosis to action theory of change. So, the Health Finance and Governance Project is funded by the USAID and implemented by APT Associates. So, we work in Nigeria, and the work we do in Nigeria is aimed at strengthening health systems and improving health outcomes by improving financing and governance for health. So, we focus on domestic resource mobilization and a mix of health financing and governance mechanisms for improving maternal and child health, HIV/AIDS, and tuberculosis. So the Health Finance and Governance Project actually started out working in 5 states, and then eventually we had to expand to about 12 states. And one of the first things that we do when we support the states is that, first of all, it's very important to us to align with the direction and the policy direction of the government. And then, secondly, we like to work based on evidence. So, before we begin to work, we like to collect information about what the current situation is. And that is what we refer to as our health financing core diagnostics. So when we do this health financing core diagnostics, we want to find out what the problems are. We need to assess what the situation is so that we'll be able to develop or define a mix of health financing and governance mechanisms that will be used to address these problems. So in the course of doing this, using an iterative approach that actually looked at, what we needed to know, the information that will be useful to policy and decision makers, the information that will address the problems and the needs in these states and the country, we kind of evolved at not just generating this evidence, but actually how we can bring this evidence together and use it to actually take decisions, enhance decision making, and enhance opportunities that are available are translating into more money for health and more health for the money in the supported states. So, in the course of doing this, of course, we learned from what we had done. We learned about what additional information needed to be generated, how all this information can come together, and how we'll be able to build on existing platforms, as well as what platforms needed to be established in order to be able to translate this into more money for health and more health for the money. And that was how the diagnosis to action theory of change evolved. So as we look at this graph, as we look at the schema, we can see that we conducted a number of diagnostic assessments in the states. The first one is looking at public expenditure review. Now, public expenditure review tells us how much the government is currently spending on health, on RMNCH and HIV/AIDS, tuberculosis in the state. So we looked at how much is being spent on health, looked at the general government expenditure, and then compared the health expenditure with expenditures in other sectors. And then, of course, we also looked at what exactly is this money being spent on? Is it on recurrent expenditure, capital expenditure? And this would actually give their decision makers and their actors in the state a good idea of what the correct spending is. Is it sufficient? Where is this being spent on? And is it spent in the right places? So the second assessment, of course, is the service availability and readiness assessment. So usually when we have this information about how much money is being spent, it's very important to find out the services that are being provided, especially at the primary healthcare level. What are the service delivery gaps? So are services readily available? what services can people receive when they go to these healthcare facilities. So this looks across human resources, drugs and commodities, infrastructure, as well as the capacity of these healthcare workers to provide quality healthcare services in the facilities. We had earlier mentioned that we align with the policy direction of the country and the states. And one of the key policy direction are things around universal health coverage. And at the moment, the policy direction is that demand side and supply side mechanisms are being used in their journey towards universal health coverage. On the demand side, states have been asked to set up state health insurance schemes that will ensure financial risk protection to all the people in the state. And on the supply side, PHCs, primary healthcare facilities, are being revitalized so that they'll be able to provide the needed services. So that when people no longer have this barrier to accessing healthcare as a result of money, they will be able to go to healthcare facilities that are functional. They'll be able to give them the quality of care that they need. So this service availability and readiness assessment aims to assess what is the current structure or what is the current state of this service delivery facilities. Are there gaps that need to be filled? And then going forward to cost it. So to say, for instance, if we need to fix these service delivery gaps, how much would it cost? Now, armed with this information, when we make advocacy to policy and decision makers to say, this is the amount of money that is currently being spent, these are the service delivery gaps, and this is how much you will need to spend to be able to fill these gaps. The usual question that arises would be, where will the money come from? And that is what the fiscal space analysis aims to address. So in the fiscal space analysis, we assess the macro fiscal dynamics to find out how much money is even available within the general economy. And then within that general economy, how much is health prioritized in the state? So this is the common picture of the size of the pie. So if the bigger the pie is, then if a health sector gets a specific slice of the pie, then it will translate to actually more money for health. But we also know that it does not automatically, this is not automatic. So in order for health to get a very big chunk of the pie, health will need to be prioritized in the state. So we look at how much is health prioritized, what percentage of the government budget or allocation goes to health. And then, of course, we also assess earmarking. So are there different earmarked funds for health in the states? For instance, some states have 1% of the consolidated revenue fund, which actually stems from the National Basic Healthcare Provision Fund that had allocated 1% of the consolidated revenue for improving demand and supply side mechanisms for improving, ensuring financial risk protection, and also making sure that healthcare facilities are ready to provide the needed care. So another place that we looked at in the fiscal space analysis are areas around efficiency gains. So we're not just interested in making sure that we have enough money for health, but making sure that the money is spent well. So how is the current spending going on? And of course, external and private financing. So what's the relationship between external funding in the states and government funding? Is external funding catalyzing increased government funding, or is it fungible? So based on all these three key assessments, we're able to take the needed evidence to policymakers to say, based on all this, we have been able to identify opportunities to spend more and spend well on health. So the public expenditure review would actually tell us how much we're spending. And then the service availability assessment would tell us the areas that need us to spend better on. So speaking to how we can spend better. And then the fiscal space analysis is telling us where the money could possibly come from. So it then becomes a problem of we don't have money, because in this time of recession, many of the states are struggling with where they can raise additional revenue from. So they find these assessments very useful to be able to say, okay, these are the potential sources of money. We know where our potential sources of money are. We know where we need to spend it so that we can get the required results that we have. So that is good news. We have identified opportunities to spend more and spend well. However, we have come to realize that identifying these opportunities does not automatically translate to more money for health and more health for the money. So, more needs to be done to be able to catalyze this potential into actual results. And that is where we have found assessment from our governance and political economy assessments very useful. So we try to examine what are those governance structures, what are the political economic factors that we can leverage on to be able to translate these identified opportunities into more money for health and more health for the money. And this would involve addressing the prevailing public financial management bottlenecks. So a lot of times we discover that even when money is allocated, it does not automatically translate to release. So, what are those bottlenecks that actually affect money being released for health? So, when we identify these governance and political economy actors, we'll be able to use them to actually address this public financial management bottlenecks and be able to translate these identified opportunities into more money for health and more health for the money. This, of course, enhances improved ownership because we have the states taking the leadership on this and being able to use their own money to be able to close their service delivery, RMNCH, HIV, TB, AIDS, and health delivery gaps in such a way that it is sustainable because they are actually using their own money to do that. So moving on to some key illustrations from how we have done some of these in the States. So looking at this table, we can see this is a table from our fiscal space analysis, looking at across three states. And when we look at this table, we'll see that we examined the different sources of additional funding and where the money could come from, which is usually the big question for policymakers. Across the macroeconomy, one of the key things we identified is that many of the states received debt relief in the past year, and 75% of this debt relief was to go towards paying salaries. Now there was a 25% discretionary part of it. So if the health sector could make a case for an increased allocation to health, targeting 15% as established by the Abuja Declaration, this will lead to additional sources of money for the different states. If health is also prioritized in the states, so many of the states are at different levels of health prioritization. Some states are doing 3%, some states are doing 5%, some 10%, some 15%. So if these states are able to reach the Abuja Declaration and allocate and spend 15% of their expenditure on health, this will lead to additional resources for health. Earmarking for health, there were different opportunities that were identified. Some of them are the 1% Consolidated Revenue Fund that should be go towards buying healthcare for the poor and vulnerable population through the state health insurance schemes. The State Health Trust Fund, some states have been able to do write a law that provides for a state health trust fund that would actually bring additional money to health. Orphans and vulnerable funds, and zakat funds, and there's so many other earmarked funds in the state. And we're able to look at how much additional money would this bring to the state. Now, external funding. There are different sources of external funding in the states. Many of them are heavily subsidized by many of them are being heavily funded by donors. But how do we make sure that this actually catalyzes government spending on health? So this is actually looking at a snapshot of the additional amounts of money that could be available to the healthcare sector if these identified opportunities are actually addressed in such a way that they would lead to results. And across the different states, we can see up a range of from 4.16 billion naira to even up to 11 billion naira that could be additional money that could come to the healthcare sector. But this does not happen automatically. So some governance and political economy actions will need to happen for that to happen. Now, some of the important information that stakeholders have found very useful in the state is the percentage of capital and recurrent expenditure. So it is often very surprising when you look across the way that government spends And we've discovered that the recurrent expenditure actually takes up the bulk of the health expenditure, as well as expenditure across the other sectors. So now, armed with this evidence, the states are beginning to look at how to improve their capital expenditure, because it is this capital expenditure that is used to ensure that the health facilities are in good form, that they are working, that the healthcare worker, that the drugs and the commodities and the equipment that they need to be able to provide quality healthcare services to the people are in place. So this has actually created the question of how do we spend more efficiently in health. Now looking at budget execution rates, so we can see that looking at it across recurrent capital and total expenditure, we can see that not just are the allocations higher on the recurrent side, but even in spending. So this graph looks at the percentage of spending across capital and recurring budgets. So we can actually say that even the recurring expenditure is likely to have a higher spending percentage than the current. Usually the recurrent goes towards paying of workers and things around that. So this happens all the time. Whereas when it comes to releasing money for basic commodities, basic equipment, and things that the healthcare facilities need to run and provide quality healthcare services to the people, we are not getting as good an execution rate as is desirable. This is an information that stakeholders have actually found very useful in making a case for more money for health and more health for the money. Now, the public financial management, an example that we took out from there, actually explains the reason why we're not reaching very high budget execution rates. For instance, across the three states, it's quite obvious that the amount of money that is budgeted, the size of the state budget, is usually very much higher, sometimes even double than the total revenue that the state could possibly make in that year. So these are based on estimates of state budgets from the previous year. So if the size of the state budget is much bigger than the revenue that is available to the state, of course, it is not surprising that the state is not able to achieve a very high execution rates and release the money as needed. Now, looking at governance and political economy findings, of course, in some of the states that we have assessed, we found that they had very good policy documents as a result of the support from different donors and sectors. However, there were no concise policy documents for health financing that would articulate how um, revenue generation, pooling, and strategic purchasing will be done. Is it you set the time? Okay, will be done. And of course, we also found weak institutional capacity to implement these policies. So there are a lot of policies, but these policies are not being implemented. Now, looking across areas of collaboration and coalition building, these were not adequate in the states. And of course, they had issues with accountability. So, what we have been able to do is provide support in the states based on this evidence generated from our diagnostics to be able to set up strong institutional structures, including a technical working group for health financing, a health financing unit within the Ministry of Health. One of the strong things that we have been able to put in place is the use of a multi-sectoral collaboration mechanism to bring all the necessary actors and stakeholders that are needed to translate these identified opportunities into results. So we've been able to set up in the states a multi-sectoral technical working group cutting across the different sectors, including health, budgets, ministries of budgets, finance and economic planning, information, the State House of Assembly. And this actually led to the establishment of a legislative network for universal health coverage in the states, where legislators come together and then they discourse and then they interact with people from the health sector and other sectors. And then they try to use their functions of legislation, appropriation, accountability, and oversight to ensure more money for health and more health for the money. Now we've been able to establish these different mechanisms in the state. We then support the state to utilize these mechanisms to actually translate these identified opportunities into more money for health and more health for the money. Now, a case scenario from one of the states is from how we have been able to use diagnostics. So basically, when we do our diagnostics, we focus on that information that will be useful to policymakers, that information that they need to be able to make a convincing case. The health sector needs to be able to make a convincing case to get the Ministry of Budgets and Economic Planning, the finance people, the House of Assembly, and even the government itself to actually respond to the needs of the healthcare sector. So we need to bring out some of this key, very important information. Now, for one of the states, one of the information that they have found very useful is the fact that 59.8% of the population are indigent population. And the state health insurance scheme, which will be starting off soon, has proposed that indigent, children under 5, and pregnant women should be covered. The government should provide for those people, while the rest of the population will need to contribute to provide, to establish a health insurance, a social health insurance mechanism in the state that will provide coverage to everybody. So, when the stakeholders are able to appreciate the fact that 59% of the population are indigent, if you add pregnant women and children under 5, that will take it to 86% of the population that will need to be subsidized for by the government. So what that means is that the government will need to make adequate money available to provide health insurance coverage for 86% of the population. Now, this graph illustrates how much of the population, or how much of the vulnerable population, the money that has been earmarked, which is 1% of the consolidated revenue fund, how much of the vulnerable population will it be able to cover? And we can see from the graph that not so much of them. So if we use 1% of the consolidated revenue fund, that would only cover 5% of the population. And 2% of the consolidated revenue fund would only cover about 7 to 8% of the population, assuming a premium rate of about 5,000 naira per person. So these are information that stakeholders have found very useful, and that has actually made them to sit up and say, we need to mobilize additional domestic resource mobilization so that we'll be able to start off our health insurance scheme, provide coverage to the entire population, especially the poor, the vulnerable, and the pregnant women. And then, of course, we were able to demonstrate to them from our fiscal space analysis the different possible sources of additional money that they could use to be able to achieve this. And based on what we saw in the States, about 5.4 billion naira is the additional money that could be available to the state if we're able to use the identified governance and political economy factors and platforms to translate these opportunities into results and into actual releases of money for health, and then using the money well to be able to buy things for the population. Of course, these additional sources of money came from debt relief if the health sector and the multi-sectoral action that had been galvanized across the different ministries is, if we're able to use them to actually make an adequate case for 15% of that discretionary funds to come to the healthcare sector. Now, healthcare expenditure as a percentage of the total government expenditure is currently at 10.7%. Now, if health becomes prioritized, especially with a new intervention coming into the state, up to 15% according to the Abuja Declaration, then we will be able to raise an additional 3.19 billion naira. Earmarking for health. So there are different places that, different discussions around earmarking in the state. We could see that 1% of the CRF could only cover 5% of the vulnerable population, and this amounted to about 580 million Nigerian naira. If this was raised to 2% of the consolidated revenue fund, that would amount to 1.16 billion naira, and that would even cover a higher percentage of the poor and vulnerable population. Now, another opportunity that was discovered was the Zakat funds, of which about the spending from Zakat funds on health every year is about 240 million. Now, if that money is directed through the health insurance scheme. This will be able to provide an additional, if 50% of it will provide an additional 120 million Nigerian naira that could be used to provide coverage for the poor and vulnerable. Now, this is a brief summary in the studied state of how we were able to use the diagnosis, looking for specific important information that the state will be able to use to actually make advocacies, to actually be able to make a convincing case for more money for health and more health for the money. Now, our service availability and readiness assessment showed that the primary healthcare facilities were in very poor states. They needed infrastructure renovations, they needed equipment, they needed drugs and commodities, as well as improvement in human resources for health. Now, an estimated 800 million naira will be required if the state prioritizes two primary healthcare facilities from each local government and decides to renovate or revitalize those two primary healthcare facilities in the first year. That will cost the state approximately around 800 million to be able to do that. And this money will need to come from somewhere. Now, looking at public expenditure review, it was discovered in the state that there was a good budget execution, they had good releases. However, this allocation and releases is still not adequate to address the health needs of the population. And if things were to continue the way they are, then they will not be able to achieve their goals and their targets. So, the fiscal space analysis, of course, then provided the opportunity for them to see where the different additional money could come from. So it became obvious that an additional 5.6 million at least can be available to the healthcare sector to address some of these already identified needs. We remember that 86% of the vulnerable population would need to be subsidized for. That is about 4.5 million people in a population of 5.3 million. If the state targets to cover 10% of these poor and vulnerable people in the first year, that will be 450,000 people that will need to be covered. And this will require 3.44 billion naira to be able to cover this. And with this information, the stakeholders have realized that they need to mobilize additional money for health to be able to address the health insurance bid, getting coverage for the poor and vulnerable, and also be able to address the service delivery needs in the primary healthcare facilities. And this led to a multi-sectoral action across the state. So now they are using this evidence, because most times going to stakeholders, you need to be armed with evidence, the type of evidence that will speak in a language that they would understand and actually address the needs that they would like to tackle. So basically, this has been used effectively to advocate for increases in budgetary allocation to the state health insurance scheme so that they will have more money to cover a larger percentage of the poor population. Increases in budgets to the state primary healthcare development agencies so that they will have adequate money to be able to renovate and revitalize these primary healthcare centers. So that once the scheme takes off and people are able to go to the facilities without financial barrier, they'll be able to meet good quality healthcare services when they get there. Of course, this has also led to an increased budgetary allocation to health in the state. However, we're still at the beginning stage, so these are all in the proposed budget. And based on this diagnosis, they have been able to successfully defend their budgets at the State House of Assembly, with promises from the State House of Assembly of even more increments in allocations to health, to the State Health Insurance Scheme, and to the Primary Healthcare Development Agency. In addition to that, having realized that more money is needed to cover for the poor and vulnerable in order to attain universal health coverage, a case has been made for an increment in the consolidated revenue fund that would be dedicated to the poor people from 1% to 2%. Remember, this will give us from 550 million naira to 1.2 billion naira, which will make it possible to cover more of the vulnerable population. Other sources of funding are being advocated for at the moment. 1% of the local government funds to raise additional money for the poor and vulnerable in the state health insurance scheme, and the Zakat funds So we had proposed 50% of the Zakat Health Funds, but based on the evidence, the stakeholders have actually said that they want to dedicate 100% of the Zakat Health Funds, and a plan and a committee has been settled to actually integrate Zakat into the State Health Insurance Committee to make sure that a larger proportion of the poor and vulnerable are covered. Other mechanisms that are being explored include contract funds. So, a percentage of every contract that goes out in the state should go towards buying health insurance for the poor and vulnerable population. And this is how we have been able to use our evidence that we have generated across the different core health financing diagnostics, including public expenditure review to tell us how we're currently spending, service availability and readiness assessment to assess what the gaps are and how much it will cost to fill those gaps, and a fiscal space analysis to tell us the possible places that more money could come from. And this led to identified opportunities to spend more and spend well. However, we had realized that these opportunities does not automatically translate to results. And so governance and political economy factors had to be utilized to be able to translate these opportunities from potential to actually kinetic action. And in the course of doing that, we had needed to address public financial management bottlenecks that were serving as impediments to actually getting actual releases of money for health, and also making sure that the money that was received is just well. In the process, we have been able to build ownership in the states, in the health system, improve multi-sectoral collaboration through the multi-sectoral technical working groups and the legislative network for universal health coverage, and use this as the catalyst to actually generate more money for health and more health for the money, and also ensure ownership, which will lead to more sustainable financing of health care reforms and mechanisms in the state. Thank you. It will need editing. Hmm? It will need a lot of editing. Yeah. But anyway,